So probably sometime this weekend or by early next week, you guys will have the midterm grades posted. So Sherry has already collected the clicker points that will be accounted for in the midterm grade. Make sure that you guys are checking in Blackboard under your lab section for your that your lab grades are accurate. And if you're seeing a discrepancy, email or talk to your lab instructor this week and make sure that you either understand and that discrepancy was actually correct, or if a score is missing or you had a deduction that you made up the lab and they didn't give you your points back, that you bring it to their attention. So do check your lab grades in Blackboard under the lab section, and they will be transferred over. And then when the midterm grades are set, I will post a posting, or Sherry will, either one of us, that will state what parts were included. So for example, one lab, maybe you guys have done only one notebook check, but other labs had gotten 2 notebook checks done. So if not all the labs had 2 notebook checks done, then it'll say in the midterm grade only 1 of the 2 notebook checks were accounted for and calculated in that grade. And the lecture exams, so you guys have had 2 exams, and similar to what we do at the end of the semester, we were only posting or accounting for in the midterm grade the top out of 2 scores. And it's kind of like as if the lower one got dropped. That score isn't completely dropped because it's not until after you guys have taken exam 5 that you guys determine whether you need to take exam 6 or not. And remember, taking exam 6 does not hurt you. Hopefully you guys have already started reviewing exam 1 and exam 2 and prepping for exam 6, because 10 questions from each of those exams will show up on exam 6. Okay. I've only had 1 person so far since the last lecture come and talk to me about either study skills or improving their grade, and I'm a little disappointed. More people should be talking to me. Some of you guys are doing great in the course, and that's fantastic. And some of you aren't doing bad and you just want to talk to me about it, that's fine too, and we'll still discuss things that might help boost your score. But if you were one of those people that happened to get in the teens, in the 20s, in the 30s, in the 40s, in the 50s, maybe even in the 60s on the exam, you should come and talk to me. I don't bite. I want to see you guys succeed. A lot of times all it is changing how you're studying. This is a college course. We are expecting you to take information that I give you and then have to apply it. It's not like in high school where you were just given the information and you just had to regurgitate it. You have to process the information and apply it now. So I know some of you guys are thinking, she tried to trick me on that exam. What a jerk. I'm not trying to be a jerk. Okay, but it is a 200 level course and you have to do that with the information. So part of studying before you guys get to exam 3 is you should take some time after each lecture and take a short break, but then go back and review the material. Explain it to somebody else. Talk about it with somebody else, something, but you have to be active in it. If you just reread it, you'll be like, oh, yeah, I remember. She just talked about it. I know this. Were you actually studying when you did that? No, not effectively. You might think you had, but that's what I'm trying to get you guys to understand. You got to switch your way of thinking, and I want you guys to try to do it now, not when it's too late. So please do come and talk to me, okay? Let's see what else. Also, if I think Sherry updated the clicker scores once, and she typically doesn't update them until around midterm. So she will update it at midterm so that you can see. But if you hadn't seen any clicker points and you were participating, whether you're an internet student doing the clickers through Blackboard or whether you're a face-to-face student doing it with the physical clicker, if you're not seeing any scores, you need to bring the clicker and your ID and see Sherry Zayo, and she will then make sure that your clicker number was registered properly. Those points didn't disappear. They're just not linked to you because something didn't get set up correctly when you initially registered it. So check for your scores, be reviewing, check your lab scores, so that way as the midterm grades get posted, you don't want to wait until the last second, and then midterm grades are posted, I think, by the end of the first week of March. So it's next week sometime that they are due. And so The only times you will see a letter grade for this course is your midterm grade and then your actual final grade for the class. Okay, that's the only time that you guys will see letter grades. And remember, midterm grades are technically a little lab heavy because they're only accounting for one of your exam scores, and then the rest of the scores are all coming from lab. Okay, so you have your fills, you'll have notebook checks, you have the bone evals are in it, the, what else would be in it? Quizzes, pre-lab scores, that type of thing. Okay, so it doesn't necessarily mean that if you are seeing a C or lower on midterms that you still can't pull through and get a great score for the class. And getting a C isn't bad. That's average, and the average for this course is going to be a C, and that's not bad. But if you're getting below average, if you were hitting below the average when we post the scores for the first and second exam, you really need to be coming and talking to me so that we can help troubleshoot and get you studying effectively. Okay, so you don't feel like you're spinning your wheels and not accomplishing much, and then you're just mad at the end of the semester and putting on my eval saying I was a jerky teacher and I didn't care about you. I care about you, but I can't care more about you than you care about yourself. So you got to come talk to me. Okay, so let's continue. We were talking about the joints. We were talking about skeletal system articulations. We talked about classification of joints. We started talking about structurally the different kinds of joints, and then we started talking about cartilaginous, and then we got into synovial joints. Now we're talking about bursa, tendon, and tendon sheaths. And so bursas are the flat fiber sacs filled with synovial fluid. I put an arrow from the notes there because I meant to write that under bursa where it said found where muscles, ligaments, tendons, skin rub over the surface of bone, reducing friction. That's where you're going to find bursas. And then I kind of pointed out a couple different places where you might see a bursa. For tendon sheaths, these are elongated bursa that wrap around crowded tendons subject to friction. So commonly you'll see this in the wrist. You'll see when they talk about when somebody says they're having carpal tunnel syndrome, you actually have an area called the carpal tunnel. You have lots of things going through the carpal tunnel, so if there is inflammation, irritation, infection, anything going on in there, you could see that you would have increased pressure in the area, and thus people get funky symptoms like nummy tingly. So to prevent some of that, you naturally have designed to have a tendon sheath in there. It has synovial fluid with it, right? Because these are things that are protecting you. Go away. Okay, so another area that you would see aside from the wrist would also be in the ankle. You would also have tendon sheaths in the ankle, especially on the inner side. A few people, unfortunately, have had to experience that. Not fun. All right, so any questions about the bursa or the tendon sheaths? And what's the purpose of a bursa or tendon sheaths? Reduce friction, exactly. Good, good, good. All righty, so now we're moving on to movements allowed by synovial joints. Again, this should be a good review for you guys because you've seen this in lab already. But gliding movements, simplest, one flat surface glides over another. So again, simplest of all of them that we're going to talk about. This might be areas such as the TMJ, temporomandibular joint, the carpals, and the tarsals. Okay. If we look at angular movements, this increases or decreases the angle between the bones. So these are the most common for angular movements, the most common type of movement that you're going to see. With flexion, it is a decreasing of the angle between the bones. So if you stick your arm out flat, okay, and flexion would be that you bend the elbow and you bring in your wrist towards your shoulder. Let's say if your arm was sticking out sideways. Do you see how I'm decreasing? This is like 180-degree angle. If my arm is out like this, let's put my, hello, I'm a happy person with a super long arm, like the Incredibles, right? Okay, and then if I bring my arm this way, am I not decreasing this angle at the joint with flexion, right? So that's what it means by decreasing an angle between bones. I'm approximating or coming closer, so decreasing the angle. And so this would be like bending your elbow, bending your knee. So flexion of the knee is this way. Okay, extension would be putting the leg out straight. Okay, and then let's see what else. And then extension is the opposite of flexion. So would I be increasing or decreasing my angle if I'm extending? I'd be increasing the angle then. And so you can put increased, wait, sorry, I put that in the wrong spot. Bless you. Come on. All right, so that was decreasing your angle. This would be increasing your angle. And then with hyperextension, this is a special case. So this would be movement back from flexion beyond the anatomical position. So this is not considered pathological. So for example, if I'm standing here and I bring my chin to my chest, what direction am I going with that? I'm bringing, yep, chin to chest would be flexion. If I tilt my head back, not extreme as far as I can go, but just tip back, this is considered extension. Now, if I really tip my head back, looking way up to the ceiling, as far back as I could go, that would be considered hyperextension. Okay? So usually if you're taking x-rays of somebody, you don't try to put somebody in hyperextension unless you're looking for a very specific view. You might just say, okay, go ahead, bring your chin to your chest, bring your head back as comfortable as you can, and then hyperextension would be past the normal. Because when we extend our neck, do we normally try to look behind us like an owl upside down though? No. So hyperextension going all the way back towards the ceiling and as far as you possibly can look. Somebody that could be hyperextended in their elbow might be that double jointed person. Remember I said they're not abinormal. They're just able to increase the angle past normal a little bit more than the average person, right? Average in the population. So when I say the next two terms, abduction and adduction, you're going to hear me say it a little differently. So in the real world, when you're out in front of other PTs and doctors and nurses and things like that, you're going to say abduction or adduction. But for purposes so that you can clearly hear how I am enunciating the word so you don't mistake it, I will say abduction or adduction. Okay, just so, but people don't really talk like that in the real world. You'll hear some people still say it because they're trying to be very clear with what they're saying, but especially for the internet students or if you're re-listening to the lecture, you can see how abduction and adduction might sound really similar, right? Okay, so one way you can remember, if you just look at adduction, ADD, add together, so think coming into the body, right? So movement toward the midline, add. Versus abduction, abduction. So abduction would be the opposite, moving away from midline. That's the easiest way I can think of to remember it. Use mnemonics, that's not a true mnemonic, but use those kinds of study skills to help you remember which is which. Add in ADD, adduction, towards the midline. So let's see, what else do I want to say? And circumduction is movement of a limb that describes a cone in space. So easiest way to think about this would be the proximal digit of your metacarpophalangeal joint would be like the tip of the cone. And can you see, like you would, if you have your finger sticking out and you could make it go around in a circle, put like this is my hand. Okay, so you can just, that would be circumduction, okay, where you can move your finger around like that. Can you do circumduction with your shoulder? Yep, same thing. I can do like the little windmill movement. That's circumduction also. And what about your hip? You think that's circumduction? Absolutely. This is circumduction. What about if I shake my head? No, is this circumduction? No, maybe if I'm rotating it around like in a circle, it would make me dizzy. But maybe if I did that, that might be. But if you're just going no, that's not circumduction. Now let's talk about rotation. So turning of the bone along its own axis. So what we're really talking about that is C1 and C2. Do you guys remember how when we looked at the shape of the vertebra, how C1, atlas, was just like a ring, and then C2 fit up inside of it with the dens. And I told you there was a ligament that's holding C2 against C1. And C2 is doing what? Or you could say C1 is doing what on C2? It's rotating. So that's where you want to think about C1 and C2. And another thing that can do it would be the radius and ulna is doing rotation. And yes, also shoulder and hip can do it too. SH for shoulder, hip. Okay, so when we talk about that, it's not the circumduction. We're talking about rotation. So it's like turning my foot, like I stick my leg out a little bit and I turn my toes all the way in and I can turn my toes all the way out. That's a form of rotation. Same thing with my shoulder. I can rotate and do pronation and supination of my hand is what you're looking at, but I'm turning my humerus and I'm rotating it inward. I'm rotating it externally outward. That would be rotation. Okay, so not the windmill move. Okay, anyway. So, and then again, you guys can use these pictures here and they're in your lab book as well, your lab manual, where it was talking about, like I showed you with the head, flexion, extension versus hyperextension. So normal range of motion is flexion, extension. Hyperextension, it's not pathological, meaning detrimental, bad, you're dying, nothing like that. It just means extra range of motion past normal extension. That's all that meant. And same thing, so you can play with abduction and adduction. So if you're in PT later and you're going to have people, or PTA program, you're going to have to check people's range of motion. And you're not going to use the term abduction or adduction to your patient, but that's what you're writing in your notes. That's what you're documenting to other doctors, nurses, etc., what the patient was able to do. You're checking that range of motion. To the patient, you're just going to say, can you move your arm like this? Can you move your arm like that? If I bring my arm, my left arm across my chest to the other side, am I doing abduction or adduction? Adduction, because I went into the midline. If I swing my arm outward, and almost like I'm trying to reach behind me, I am now doing what? I'm going away from the midline, so it's now abduction, away. Okay, so play with it with yourself. Go back and review these terminology later on today or tonight, or go to sleep and do it tomorrow. I don't care. But review it again so that these make sense, and then apply it to yourself, because that'll help you remember it. All right. Woohoo! Look at all those fun ranges of motion to play with. So special movements. So we have supination, which we talked about, like doing the soup spoon. So turning your hand like a spoon, cupping upward, would be a supination movement. Versus pronation would be emptying the soda can, dumping it out upside down, or the beer can, whatever you want to say, right? So pronation would be turning it down. So we have movement of the palm anteriorly. These are all talking about put yourself in anatomical position first. When you guys are on the exam, put your body in anatomical position and then answer the question, okay? I don't care if you have to stand up for a second and do this and think about it. I don't care if you're sitting down and you're going like this. I don't care. Just don't look at somebody else's exam. But you can do it to yourself, and that will help you on the exam, and that's okay. Pronation is the opposite of supination. Let's see, dorsiflexion of the foot. So these can get a little funky sometimes. So if you think like the wrist, dorsiflexion is like wrist extension. So if I bring my fingers towards me and I'm in anatomical position, that would be wrist flexion. Extension would be my palm going outward away from me, or the dorsum of my hand extending backwards, correct? So dorsiflexion is like flexing your wrist. Remember, the dorsum of the foot is like the back of your hand. Okay, so dorsum flexion, dorsiflexion, you're popping the toes up. Okay, so let's see, what do I want to say? So think of like if you were to stand on your heels with dorsiflexion. Okay, if I'm standing on my heels, the dorsum of my foot is flexed towards my leg. So think of that as dorsiflexion, think stand on heels. And again, this will make more sense to you if you act it out on yourself. It will help you remember. So what do you think plantar flexion is? The plantar surface of your foot is on the bottom of your foot. It's like the palm, but it's the bottom of your foot. So plantar flexion would be standing on your toes, okay? And do relate the foot and the wrist together. Hint, hint, wink, wink, nudge, nudge. Relate things together. You'll see things like this on the exam. Okay, let's see. All right, inversion. So, foot is moved so that the sole, bottom of your foot, faces medially. So if you think about the bottom of your foot facing medially, right, you're putting pressure on what side of your ankle? Laterally. This is the most common way people sprain their ankle. You know, you're walking and all of a sudden your ankle, you know, you go, your leg is trying to go lateral, your foot rolls in medially, inverts in, and so that's inversion, okay? So you could think inversion in, the bottom of the foot is rotating in, okay? Or you could think inversion is like your feet trying to clap. So the palms of your feet, the soles of your feet, the bottom of it, and trying to clap them together, right? If I'm putting my feet like this to try to clap my toes, my feet together, right? Feet, okay? So eversion must be what? The opposite of inversion. So now it's the lateral part of your foot is sticking up. It's really awkward to be inverted. Do you see why people don't really sprain their ankle in eversion? Okay, so just think about it when you're walking and you like roll your foot out and you're like, oh yeah, I inverted and sprained my ankle. So play with those words, right? Let's see. And protraction. So this is movement forward in a transverse plane. So if you take your jaw, and we're talking about like the TM joint, and you just push your mandible, the lower part of your jaw, forward, not up and down, not opening and closing, but just forward. Do you see how if you jet your jaw out, that's what this is talking about, okay? Another thing that you could do would be like your shoulders. So protraction would be moving forward. So it's like when you push your shoulders forward, almost like you're rounding your upper back, but just think about you're only moving your shoulders. That would be protraction. So retraction would be back, okay? Bringing your shoulders back or pulling your jaw back in, correct? Okay, that was retraction. Then elevation would be lifting a body part superiorly. So you guys all know how to do this. Say, I don't know, and shrug your shoulders. There you go. Okay, so that's elevation, shrugging your shoulders. Okay. And depression would be opposite of that. So it's kind of hard to depress your shoulder. You kind of can, I guess, but it's not always comfortable trying to shove them down. They don't really go that way so well. And then opposition is talking about when you bring like your thumb and a couple fingers, like your thumb and pinky together, or your thumb and your middle finger together, that would be called opposition. So this is part of what makes us humans and able to use tools more so than other animals, okay? Because we can do opposition. Classification of synovial joints. We're going to look at 3 of them: uniaxial, biaxial, and multiaxial. So let's see. With uniaxial, bones move in just one plane or axis. So this is a like gliding with flat bones, if you will. So if you want, you could kind of think of it like here's a bone and here's a bone, and then they can glide back and forth, right? Okay. So think of sliding or slipping over the surface. So this could be like intercarpals, right, between your carpal bones, the wrist bones. So gliding joint, flat surface of one bone against the flat surface of another one, just in one plane. Okay, so there's no rotation, there's no other funkiness. It's just, think of it almost like a shearing motion back and forth, right? It can move that way. That's it. A hinge joint is also a uniaxial. So we can have plane joints, hinge joints, or pivot joints that are all uniaxial. So the plane joint is just that 2 flat surfaces. A hinge joint, you could think of like the elbow joint, right? Could be like the knee joint. That's a hinge back and forth, right? So it looks basically like the hinge on a door jamb. Okay, so you have kind of like if I were to do the elbow here, you have that, and then you have a bone that looks like this, and you can tell that it just goes in that back and forth direction like a hinge. Okay, And also, I said elbow, knee, and also interphalangeal joints will be on a hinge. So we have intercarpal on plane. We have elbow, knee, and interphalangeal. If we look at pivot joints, so this is rotation in one plane. So who did we say can rotate a second ago? C1 on C2 is rotation. And also the proximal radial ulnar joint. So proximal radial ulnar joint. Okay. And let's see, what else do I want to say? I didn't draw a picture of it, but you guys can think of C1 and C2 and what we already described. If we look at a biaxial, bi is implying two, right? So biaxial is movement in two planes or axis. So this is going to include the condyloid and the saddle joint. And when you first look at these, they seem a little strange, but when you think about it or see the picture down below, it'll make more sense. So a condyloid joint is an ellipsoid joint, back and forth, as well as a side-to-side movement is what it allows. So you'll have one bone that kind of has this roundy part to it, and you'll have the joint to another bone that has almost like that cup shape to it. So that's the ellipsoid part to it. So it allows for rocking as well as side-to-side motion with that. It allows you to do basically flexion, extension, abduction, and adduction. And this is easy to do with your metacarpal phalangeal joints. Okay. If you look at a saddle joint, just think of what a horse saddle looks like. Okay. So I'll show you the picture in a second, but basically if you think of a horse saddle, you have, you know, a rounded part of one joint, and then you have another joint kind of crossing over it like that. So the roundy part of one and the opposite direction, so one is convex and one is concave, but they're going over each other. So if this was like the horse's back, so I'll put H back. You guys are going to be like, what the heck did H back mean? Then the saddle that's fitting over it, you're talking about the underneath part of the saddle fitting on the back, not the top of the saddle that your bum sits on. Okay, you're talking about the way the saddle sits on it. So the underside surface of it, okay? So that's a saddle joint. So it's concave and convex. I don't know why it says concave. I guess you could think it's two concaves over each other if you want to think of it that way, but truly this is still concave, and this underside of the saddle would be convex then, right? That's what it's talking about. So it really is concave and convex. But if you're looking at the top, the joint isn't the top, it's the inner part. That's why you have to look at the, so it's concave and convex articulating surfaces, special case for, guess what? The only one that does it is your thumb, right here. That's your only saddle joint. And let's see, what else do I want to tell you? So to remember a saddle, just kind of have one hand and then place your other hand in the shape of your fingers as like a shape of a C over it. That's the idea of the saddle joint. Concave on the bottom, convex on the top, sitting on it. It's different than this condyloid shape. And look at the pictures in the text or the picture in a second and it'll make a little bit more sense. On multi-axial, so this is movement in a multiple planes or axes. So this is going to be, for example, your ball and socket, which is the most freely movable joint that you guys have. And we only have two ball and socket joints. One is your shoulder and one is your hip. So shoulder and hip, that's it. And if you think about the ball and socket, so the shoulder, remember, is a very shallow ball and socket, but the hip is the more obvious where you have your acetabulum of your actual os coxa bone, and then you have the femur coming in. That's a funky looking trochanter, isn't it? So this is your ball and this was your socket. Okay. Look, I even have a fovea centralis on it. Alrighty, so if you guys are looking at these pictures, again, here was your plane joint, uniaxial, right? Only one plane that it's moving in. We had the hinge joint there. Here's your ball and socket that was there. And here's your pivot joint, so that's your C1, C2 type of area, which they give you a picture of that. This was the condylar joint, so this is shaped like this, and then this is shaped like this underneath it, okay? And then, like I said, the saddle joint is kind of funky because you've got your ridge here and your ridge here, the way it sits. But think of it more like a C over the other, okay? All right. Was that fun or what? Moving on to selected synovial joints. So now we have some special joints we want to talk about, such as the knee joint. My notes are a little different. Are your notes different? Maybe, apparently, we will come back to synovial joints and the lever system un momento. So maybe it's going to be with the muscle section. It's E for you guys. I have D, synovial joints and levers, and I have the lever system, first, second class, third class in my notes. And then power versus speed. I will mention it now, and if we see the pictures later, I'll talk about it, because I obviously don't have the pictures here, and it might be that it got moved to the muscle section, because some of it will make more sense when you talk about muscles. But under synovial joints and levers that you guys have in your notes. So talking about lever systems, this is talking about movement with the joints and how we move them. So it's bone and joint and muscle. Okay, so that's why we might see this in a little bit. So the term lever, fulcrum, effort, and resistance. We want to talk about those four things first. Lever is an elongated, rigid object that rotates around a fixed point. And so, for example, what do you guys think the lever is referring to? If I have to pry something up and I need something long to push down on, my lever would be a bone on me, okay? I'm going to write it over here. So when we say lever, we're talking about bone. I'll put lever systems here. If we're talking about the fulcrum, okay, what do you guys think I'm talking about that? It's a fixed point. That is the joint, okay? And if I'm talking about effort, now I'm talking about something that's applied to a point on a lever. So this is where we're talking about muscle. Okay, now resistance is located at another point on the lever. This is where movement can occur, but effort has to overcome resistance in order for you to actually move it. So this is something with weight that you have to lift. So we'll have resistance. Resistance is going to be the load which you're trying to move. So resistance is going to be the load. Now sometimes the load is on us, it's gravity. We're always pushing against gravity. Our spine's pushing against gravity. If you try to lift your arm up, you're going against gravity. You just don't notice gravity because you've grown up with it your whole life, never known anything different, so it's not like you feel this weight there. But when you get in the water, you don't feel gravity because you're buoyant. Or if you went into outer space, you don't feel gravity, okay? So that's what that part is talking about. As far as a first-class lever system, so first-class lever system, anything that it's talking about, and then we're going to have a second class. Let me write this down real quick. And you're going to have a third class lever system. So whatever is in the middle is what's designating whether it's a first, second, or third class lever system. So with first class lever system, the fulcrum will be in the middle. And what was fulcrum referring to? That's the joint. So it's saying the joint is in the middle between the effort and the resistance. Okay? So we're saying fulcrum's in the middle between, we said, resistance and the effort. Okay? In a second class lever system, the resistance is what's in the middle. And so what we're talking about there is the resistance is the weight or the load, okay? So we're saying, so we can put resistance, wait, what did I say? What are we doing? Resistance, second class, between the fulcrum and the effort. Resistance is in the middle, that's the load. Yes, so also put load. That'll help you remember that. So if we have our system here, we have a resistance in the middle, then we can stick our fulcrum at one end, and we'll put our effort at another end. Okay. Then if we look at a third class lever system, the effort is in the middle. Pretend that E looks good. And effort was what? Your muscle, right? MM for muscle. And so if we drew a picture of that, that would be, we're saying the effort's in the middle, and we have a fulcrum at one end, and we'll have resistance at the other end. Okay, so later on, practice drawing, reminding yourself what a lever, what a fulcrum, what an effort is, who's the bone, who's the joint, who's the muscle, what the load is, what's the difference between a first, second, or third class lever. But then you guys have to apply the knowledge that you're understanding. So for example, if you have, there's another way to help remember the order of first, second, and third class. And it's the mnemonic FREE, F-R-E, right? So first class, resistance is second class, effort is third class lever. What's in the middle, right? So FRE, what's in the middle, designates whether it's a first, second, or third class. So you can do that, FRE, as your mnemonic of whether something's first, second, or third class lever. What's in the middle? So if, let's say, on your first class lever system, the idea is to think about how would you maybe make it easier or harder? Or does something have mechanical advantage versus a disadvantage to what you're trying to do? So everybody's done various things where they tried to lift something too heavy for themselves. So you can relate it to that. The first class lever system is more like a seesaw, right? So you have the fulcrum in the middle, one kid's on one side, one kid's on the other, and you're bouncing back and forth. But let's say if you elongated your length of one side here, okay, and would that make raising the resistance easier or harder? If I shortened it, would I make it easier or harder? It would be harder. So if I elongate it, I've given myself like a longer lever system, it's actually going to be easier, unless you have a weak stick and you break it. Then that sucks. You got to start all over again, right? But let's say, so if you elongate this longer, you actually made it easier. But let's say also, and if you moved your effort to this end, you would make it easier, more mechanical advantage. But what if you moved your effort closer to the fulcrum? Easier or harder now? Harder. You'd have to use more effort to lift or do whatever you need to do for this resistance. Okay, so play with that and think about it in real world terms and stuff. If you look at the second class lever system, think more like a wheelbarrow. So where the fulcrum is, that's your wheel, right? And where the effort is, that's you lifting up the handles of the wheelbarrow. And your resistance or load is inside your wheelbarrow. That's this guy right here. Okay, so again, if you had a shorter wheelbarrow arm, you would make it harder. If you had a longer wheelbarrow arm, you're probably making it easier on yourself. Mechanical advantage or mechanical disadvantage? How much harder do you have to work for it? On the bottom one, so that's your third class lever system, a good example would be like when you're trying to shovel snow, right? So snow shovel. So for example, in this case, the resistance would be like your snow. Okay, here's your shovel. Here's your handle at the end. The handle is the fulcrum. Okay, your effort is going to be where you're actually lifting something or not. So if your effort is back here at your fulcrum, did you make it easier or harder? Harder. You made it a lot harder. If your effort, if you move your hand down further here to lift up that resistance, the snow, you've now made it easier. So more mechanical advantage. The main type of lever system of our bodies is the third class lever system. And if you look at, they don't have the picture in front of you, but you might in your own notes, if you look at the picture of the elbow, so the brachium, antebrachium, so your muscle, right? The muscle is the effort. So let's talk about our bicep muscle. Is the bicep muscle near your fulcrum or far away where it attaches? Where does your bicep muscle attach on your antebrachium? Really close to the elbow or really far near the wrist? Really close. So this is why it's a third class lever system. It's way back here, okay? And are we at mechanical advantage or mechanical disadvantage with this system? Disadvantage, correct? Because we're close to the fulcrum, which is your elbow joint, okay? So yes, some people are going to be stronger than others, but overall, if our muscle were attached closer to the wrist, we would be able to lift even heavier things, right? But we would do that at a cost to our range of motion and our agility and ability to hurry up and do other things. Okay, so we would, when you have a mechanical advantage in one way, you might cost it in another way. So because we have increased range of motion with our arm and whatever else we can do here, and with a lot of our other lever systems, we may not be as strong as we could have been if we were designed in a different way, but maybe this agility and increased range of motion is what has allowed us to survive and become the species that we are today. And we have other ways of lifting heavy things, right? We can use other lever systems to do what we want to do. So think about how you would make this at more mechanical advantage or disadvantage, depending on where you would move the effort or the fulcrum or something like that. But relate it back to like that lever system. Don't just think of it on your body. And then if the question asks you to relate it to your body, you can go back and see how can I make this better for me. But most of ours is a third class lever system on our body. Okay. And let's see. So selected synovial joints. Now we're at the knee. All right. So knee joint, largest, most complex joint in the body. Okay. So our knee can do things like flex and extend, which that one's pretty obvious to us, right? But another thing that it can do is when it is a little bit flexed, it actually can rotate slightly. But we are not as strong. The joint is a little sloppier, meaning it has a little more play in it when it's slightly flexed. And that allows for increased likelihood of damage or getting hurt. Okay, so when flexed, it allows for a little rotation. So that's the other plane. So when flexed, it allows for some, I'm just going to put ROT for rotation. So we have flexion, extension, we have rotation. And then that is what will end up causing you some stability, because when you have that extra range of motion in there, you've cost yourself a little stability on it. So you're more likely to have injuries. So we call this a 3-in-1 joint also, or another name for that would be a compound joint. Okay, so one would be the flexion extension between what two bones? And you can cheat, look at the picture. The femur and the tibia, correct? So that does flexion and extension. Another joint is the patella and the femur. Remember, on the femur you have a patellar surface, so that's another joint range there. So that's the second joint we're talking about. The third joint we're talking about would be between the, think lower extremity. Fibula. Yes, tibia and fibula. Good one. So, and so you have that interosseous joint. You have, not the interosseous joint, but the joint between the actual, at the bony part, up near the knee. Remember, the tibia is not articulating with the femur, but the whole joint complex is made up of those 3 different joints, okay? And then this joint also has many bursa, which we kind of talked about in the last lecture, I think it was, yes? Okay, so if you guys look at this picture, I know it tells you, but try without looking at the teeny tiny text in your notes there. Can you tell which one is the right or the left joint? Is this a right or a left? Is this all left, all right? Okay, so which one? Let's do this first one right here. Is this a right or left knee?
Both right.
They're both right. How do you know it's a right knee without it telling you? Look at the fibula. The fibula, is it a medial or lateral bone? It's a lateral bone. So here we have we know is our fibula, and the reason you know whether it's right or left is this is the anterior part of the knee, or what we're facing there, because you have you have the tibial tuberosity there, okay? And you also have your patellar surface here, okay? So look for those little landmarks that you know are on the bone and helped you orient yourself in the bone eval to what you can see in here. So this has to be the posterior side, and again, lateral bone. So if we're looking at the back side of the knee and the fibula is on the lateral side of it, then that has to be, I put L for lateral, not L for left. Then if that's lateral and we're posterior, this has to be a right knee. Okay, so use these things that you guys have already learned, but apply it so that you can tell what you're actually looking at. All right, and let's look at the hip, another selected synovial joint. So ball and socket joint, deep and stable. So let's see, Okay, so ball and socket means a lot or a little range of motion. A lot of range of motion, right? So it needs extra capsular ligaments to help stabilize the joint so that we don't get super funky looking, right? So it has actually several extracapsular ligaments. I'll just put LIG for ligaments. And those help stabilize the joint, okay? And extracapsular means outside the capsule. So these are outside the joint capsule. And again, the hip is ball and socket. It's deep and stable. If we look at the elbow, okay, so stable and smooth, right? It really doesn't do anything but this, right? Does a little bit extra. So remember when I talked about Popeye's elbow, right? So what would you say, because that's really more like a layman's term to say what that was. What bursa anatomically would you call what I call the Popeye's elbow? Think about what bone you're near, what area of a bone you're near. Remember, if I put my elbows on the table, I'm on my olecranon. So it would be an olecranon bursa, right? See, all right. So this is also a 3-in-1 joint. Okay, so you have the humerus and ulna, which allows for what range of motion? All right, so we have flexion and extension, and that's with our humerus. It's so funny. Humerus and ulna. That's a U. Now you're getting okay. And then you also have the humerus and the radius. And you also have the radius and the ulna has a joint together at the proximal end. Radius and ulna. And so not only can we do flexion and extension that we just mentioned, but what else can we do? No? Well, yeah, because of supination and pronation. Okay. And you can also do supination and pronation when you're doing flexion and extension. Look how awesome we are. We can do all kinds of crazy things, right? So we don't have to be fully extended to be able to supinate or pronate. We can do it in midair while we're doing it. Right? Jazz hands. All right, so now let's talk about homeostatic imbalances of the joint. What does that mean to you? Back in the first exam material, we talked about homeostatic imbalance. It means something's not right, correct? Homeostatic would be a good thing, but when it's a homeostatic imbalance, it's a bad thing. So it's not good when you have a sprain, right? So sprains are on the ligaments. A strain would be a muscle tear. Okay, so a sprain is ligaments are stretched or torn. Because we're talking about joints, we're talking about a sprain of the ligaments that are protecting that joint. Okay, so these would heal slowly because what do you think? Yeah, heal slowly because it's avascular. There's very little blood supply near the area. It has to get it from other areas, right? Nearby areas, but it's going to heal slow. If you really tear it bad, you probably have to have surgical intervention to fix it. Okay. So due to poor vascularization, poor nutrition, ligaments are made out of dense, regular connective tissue. Dense, regular means you don't have blood vessels that can fit through it. It's not like dense, irregular or areolar CT. So this is dense, regular. That's why there's lack of blood supply. Thus, healing is slow or non-existent sometimes. Okay. Let's see. So the blood vessels are nearby or around, but they're not actually in the ligaments. And cartilage injuries, another homeostatic imbalance. So mostly referring to tearing of, usually we're talking about the knee menisci, which are our shock absorbers, right? So these rarely repair on their own. How many people do you know have actually had to go get their knee repaired, like orthoscopic surgery, knee replacement later on down the road, something like that? So people will deal with it. People will get catching. People will have pain and discomfort. They'll just live with it for a while until they can't anymore, and then they finally have to have surgical intervention. And they might try some other things to lubricate the joint. A lot of those are temporary. When I say temporary, it might last a few months. It might last a few years. They might go many years where they're not in too much pain. It's not great, but it's not horrible. They're living with it. Okay? So that's why I say sometimes somebody will get an injection and say, man, that lasted for 10 years. I felt great. Then I injured myself again, and the injection didn't work this time. Yeah, you might have to go see the orthopedist this time. I'm sorry. It sucks. So why does it rarely repair itself? It's also cartilage, so it's avascular. So rarely repairs. And typically we'll need a surgical intervention at that point. So cartilage is avascular, difficult to heal. Let's see, bursitis and tendinitis. Anytime you see itis, it means inflammation of the whatever's in front of it. Bursitis, inflammation of the bursa. Tendinitis, inflammation of the tendon. So typically, this is going to be due to trauma. And remember I said overuse could be a trauma. So some sort of repetitive thing that you're doing over and over again, writing copious amounts of notes will give you tendinitis. If you play a sport and you do the same thing over and over, for example, like let's say you are softball or baseball pitcher, every time you throw, and you're repetitive and you're always right-sided when you do it, let's say, or if you're left-handed, left-sided, whatever. But that's a type of trauma, okay? So that could cause bursitis or tendinitis. So most common, I'll put MC, is due to overuse or trauma, because overuse is a trauma. Overuse or trauma. And less common, but can happen, would be due to an infection. Could cause tendinitis or bursitis. So less common would be infection. So for those people, remember I said, they might have to pull fluid off to make sure it's not an infection. And if it's not an infection, they can pull the rest of the fluid off, or they'll give you maybe an anti-inflammatory to calm it down and tell you not to do that repetitive, whatever you're doing, stop doing it. Give it some rest, ice, let it heal, that type of thing. And then for, if it were an infection though, they might have to give you an antibiotic if it's bacterial, clean it out, lots of different things they might end up doing just depending on what kind of infection it was due to. And let's see so treatment would depend on that one, but you guys know if it's overuse or trauma, stop doing it, right? Give it time to heal, that kind of thing. Arthritis. So this is another homeostatic imbalance. What? This isn't normal for people? No, it's not normal for people. Does it happen typically to people? Yes, it can. So inflammatory or degenerative, there are actually over 100 different types of arthritis. Most people, most of you guys have only heard, and most patients that come in will only know of, oh, I have degenerative joint disease, DJD or DDD, degenerative disc disease, right? So these are inflammatory or degenerative diseases of the joints. Osteoarthritis is like DJD. It's another name, or you'll hear it termed OA. OA for osteoarthritis, okay? So this is the most common type. It's a chronic wear and tear type of arthritis. So you ever had an injury in sports or as a kid or whatever, and then later on down the road, now you have elbow pain or knee pain, and then they take an x-ray because it's not going away. And typically this slowly progresses. It doesn't mean that you tripped that day and the next day you have OA. Absolutely not. This is a slow progressive thing. Now you might have tripped and it was already underlying in there from years ago when you injured yourself, but you didn't know it till you injured yourself, and now you woke everything up and now your body's thinking about it and now it's really painful. But osteoarthritis takes time, like months and months and months or years, or serious trauma that then caused you to walk different and put more wear and tear on another joint that then caused it to have OA. So this is where the articular cartilage is gradually worn away. Where is the articular cartilage? Ends of the joints, right? And that's why we put gradually worn away. Gradually, because it takes time. Worn away. Okay, so this is due to trauma causing inflammatory enzymes to be released, which is going to, irritate the area even more. And this will erode the cartilage faster than it can actually repair it. And remember, cartilage does not repair easily because it's avascular, right? And then the exposed bone responds by forming bony overgrowth. And what do you guys think that would be called? Bone spurs, right? So different areas of the body, it looks different. Like in the spine, people will have something that kind of looks like a bird's beak in the spine as a bone spur. You might see the tibial eminence on the tibia bone, and they'll look more pointy and funky looking inside the joint over time because stuff was tugging on it, rubbing against it, that kind of thing. So depending on where you're at, you might see increased bony growth, thus bone spurs in those areas. And then if you have increased bony growth, what do you think that does to the range of motion of that joint then? It's going to decrease it. It's going to lower it. You're not going to have as much range of motion then. And it's a slow, and we say debilitating process because it's not completely debilitating in the sense of, one day you're walking around, the next day you're using crutches or a wheelchair. But over time, as it deteriorates more and more or becomes more and more uncomfortable and thus painful, it does become more debilitating. You can't do the things that you used to do, right? You can't jump off a wall and be like, hey, I'm a 5-year-old. Look what I can do. Look at what I can do, right? Anybody ever see that on Saturday Night Live? Yes. This tends to affect women more than men. Okay, so let me add this in real quick. Right. Stop touching me. Okay, let's add those notes in really fast. So we said articular cartilage is gradually worn away. It's due to trauma causing inflammatory enzymes, ENZ is my word for enzymes, to be released, which erode the cartilage faster than it can repair it. Oculus reparum. The exposed bone responds by forming bony overgrowth, okay, which are AKA bone spurs, that's an S, which ends up decreasing your ROM is range of motion. That's the shorthand for range of motion. And then it's slow, debilitating process, and it is irreversible. So you'll hear people say, oh, I went in and they did like a Roto-Rooter thing and got rid of those bone spurs on my spine. Yay. Still had to rest and recuperate and do other things. And guess what? After that surgery, you'll get more bone spurs later because you just created a new trauma to the area. I'm just saying. But anyway, this affects women more so than men. Probably has to do with the type of enzymes or the cartilage itself, maybe the range of motion of the person or the activities that they were doing. Who knows? I've had housewives that didn't have as difficult a housewife job as some housewives do nowadays. And they just kind of had a very relaxed lifestyle and they had tons of arthritis. But inactivity can increase osteoarthritis too. So maybe that person had more than, say, another housewife who is like taking the kids to and from school, the doctor's visits, this, that, all the sporting activities, cleaning the house top to bottom, helping with this, that, and the other thing, and they're doing all kinds of crazy stuff. And you could say, well, men do a lot more heavy lifting sometimes and doing this and that and manual labor and who knows why, but in the population, women tend to be affected more than men on this. And remember I said there could be like tons of other types of arthritis. So we just talked about osteoarthritis. In a minute I'm going to talk about rheumatoid and gouty arthritis. But there are lots of others like psoriatic arthritis. There's lupus. There's juvenile rheumatoid arthritis. There is arthritis due to a virus. There is arthritis due to if somebody had gonorrhea. And you don't hear about that so much, but it's still around, people. Yep, venereal diseases. And so anyway, let's talk about only these three, though, for what I need you to know for the exam. So, yes. Would that kind of go with PD? On the PD as in public disease? Pelvic disease. Pelvic inflammatory disease from a possibly anything that causes inflammation could potentially turn around and cause not necessarily osteoarthritis because that's more wear and tear, but it would have another arthritis associated with it. Might be PD, PD arthritis or something like that. So lots of different ways that something could be termed arthritis, anything that causes inflammation. And a lot of the autoimmune type problems, and we don't get into autoimmunity until 228, but a lot of autoimmune type problems have arthritides that go along with it. So lupus tends to be more autoimmune type, rheumatoid tends to be more autoimmune type, and then they also have other things that go with it. And they have very specific things that we're not getting into in this class, but that you can see on an x-ray of how the bone deteriorates and in what areas first before another area, like fusion of the spine from top down versus fusion of the spine from the bottom up. Ankylosing spondylitis affects men more than women and affects the SI joints first and goes all the way up the spine. And eventually, maybe not in your lifetime, maybe in your lifetime, would fuse the whole spine together. Rheumatoid affects women more than men and fuses your spine from the top down, all the way down to the SI joints. So lots to know. We're the tip of the iceberg in here, guys. Be happy you don't have to know the tip of the iceberg for our exams. So rheumatoid, so just for our exam, yes, there's like a gazillion arthritides out there. Just know osteoarthritis, and then these next two, rheumatoid and gouty. So with rheumatoid arthritis, this is a chronic inflammatory disorder. So inflammation, it's an autoimmune problem. See how fascinating A&P is? You could learn so much, and we just don't have time to cover everything, but it is so cool. So an autoimmune problem, it can be triggered by, not all of it, but can be. One of the things might be streptococcus, and you're going, what? streptococcus, or a virus. So you're telling me I could get sick and then I could end up with rheumatoid because I ended up with a virus? Yes, it could potentially happen. So you're telling me that I could have strep and then end up with this? Yes, that could potentially happen. This is one of the ways that it could happen. There are other ways that you could get rheumatoid, and it might not have been due to those. But how often does somebody finally get diagnosed with it and then look back in their history and know that it might have been the virus or streptococcus that ended up causing it? Maybe it's all due to that. We just don't know because it doesn't usually come up until later. Women, it's going to be in their 30s and above. You don't have to know that for the exam, but most of the time. JRA is different, juvenile rheumatoid arthritis. They're going to know they have it since they were pretty young. And it's a little different than RA, which will affect women more than men, and usually around age 30 and up is when they start to see it. So this is bone and joint destruction. You're actually destroying it. It's chewing it up. So bone and joint destruction occurs from synovial membrane, I'm just going to put MEM, membrane hypertrophy, enlargement of the body, right? Hypertrophy, and erosion of the bone. That means eating away of the bone. Rheumatoid arthritis sometimes will look similar to lupus. We're not going to talk about lupus in here, but both of those have what's called an ulnar drift, meaning that I'm not standing in anatomical position, but it would mean that my pinky would approximate to my antebrachium. So laterally turning my hands out. If I was in anatomical position, I guess you could say medially coming in, but usually people have their hands out, palm down, looking at you, and you'll see their hands are sticking out to the side. That's not normal looking, correct? You don't see people go, hi, how are you? I like to stand like this. No, but it is very obvious when you see, and it's because the bone is eroded there. The ligaments get eroded. And it can't, in rheumatoid, it cannot come back to midline. Okay, lupus, it can, but we're not talking about lupus. So rheumatoid, they're stuck out there. And guess what? It can also happen at the ankles. So they'll also be turned out towards the pinky side also. It doesn't mean they will have it here on the hands and the feet. They may have it only in one area. It might end up on one side before it ends up on the other, but eventually it would be symmetrical, bilateral, both sides. So the streptococcal part that we were talking about, so streptococcus, some people have a surface marker on their cells. This is why I say this comes more into play in 228 with immunity. And those surface markers on your cells tell you that you are you. This heart cell is your heart cell, not somebody else's heart cell. This red blood cell is your red blood cell. You didn't get a transfusion from somebody else. This one was you and it belongs in you. But if you get something put into your body that doesn't belong to you, it doesn't have the right surface markers. It's like the fingerprint on the outside of the cell tells your body this isn't you, so then your immune system would go and attack it. Well, sometimes the streptococcus has surface markers that are similar to some people, not the entire population. So your body sees it, attacks it, then it goes, this is the part that's wrong and doesn't belong here, and then all of a sudden starts attacking your own cells that have the same surface markers and says, ooh, you don't belong here either, out, get out. Okay, so it's autoimmune, your body's attacking itself. It thinks that you, that cell in you did not belong there and starts trying to get rid of it. That's what's happening there. So that's why sometimes with streptococcus might cause this to happen to somebody. So the ulnar drift happens at the MCPs, metacarpal phalangeal joints. It's eating up the hyaline cartilage, which is why you're seeing the synovial membrane, hypertrophy and erosion of the bone area. And again, this is women more than men. Okay, so men can have rheumatoid arthritis, but it's typically going to be female. If we look at gouty arthritis, which is excess uric acid crystals in the joints, okay, this one is unique. Yes, go ahead.
I have a quick question. So I've heard that children can grow out of JRA though. So how is that possible? It's not.
I would say they're oftentimes on a lot of different medications. I would have to look it up to see, but the people that I know that have had JRA do not grow out of it. Okay. I am not sure, and I'm not going to say 100%, and I'm not going to say like some of the medications they are on help keep it low grade. But even some of the medications one of my patients was on was actually a cancer chemotherapy drug. And on parts of it, it made her really ill and sick. But on the other side, she was feeling much better on the other hand. So which way do you want to feel? Sick and ill, or painful joints all the time and all these other things? It's not fun. And it'll flare up at times and be worse than other times. But maybe hormonal changes might affect it a little bit. So maybe if it's a female and they end up having children or going on birth control, I would have to look into more and see if that actually affects it a little bit. She had 3 kids, so I'll have to ask her if that made a difference while she was on it. Probably she felt worse because she couldn't be on certain medications while pregnant, so I don't know. I'll have to double check on that, but I don't believe so, but I double check on that one. All right, so gouty arthritis, excess uric acid crystals in the joint. So this is usually going to affect men more than women. Again, you could have a female patient. I had a female patient that had it, and I was like, this really looks like gout to me, but you're not a guy. All right, let's check it out. I'm going to send you to the rheumatologist. Usually treat all of these people. Not that a primary care can't, but a rheumatologist is a specialist for arthritis type things. Okay, so this is men more than women are going to get this, and it's due to men having more uric acid because they have a larger muscle mass, and uric acid is a cell waste product in general. So men have more. That's a regular U, uric acid. Have more uric acid, usually because they have larger muscle mass. MM for muscle mass. Okay. A hallmark sign of this, and this is what my female patient had, was big swollen red toe, pain at the big toe. It doesn't have to be at the big toe. It could be somebody's elbow. It could be where they'll have other things that go along with gout, and you'll see things about their ears that are another hallmark that could be it. But it could be any joint. It just depends where the uric acid crystals are accumulating. So it's coming out of their blood and accumulating in the synovial joints. But a hallmark one is almost always somebody comes in with a big, swollen, painful red toe, and usually they tell you they've been eating certain kinds of foods that tend to make it worse. So we're going to talk about what to avoid to not have this problem. And I'll just say, you don't need to know this part for the test. Tart cherry extract works amazing for this. But you will have some patients that will actually be put on like allopurinol, which is to reduce the uric acid crystal formation. So basically, because it's due to purines is what it is. So uric acid crystals accumulate in the blood and synovial fluid in the synovial membranes. Crystals are sharp, little pokey things, right? Even though if they're really tiny, but look at some salt crystals. Pour it out in your hand. It's kind of scratchy feeling, right? Think about that in your joint and grinding around when you're moving and trying to do stuff. No wonder it's painful, okay? So things to avoid. Hydration is the key to stay hydrated. So avoid getting dehydrated, okay? So hydration is key. And what we mean by that is avoid alcohol, because what does alcohol do? It dehydrates you. If you guys are in chemistry, you might see this as ETOH. Ethanol is the shorthand for alcohol. But so avoiding alcohol because alcohol not only dehydrates you, but it also promotes excess uric acid production. So it will also promote more uric acid crystals, and you're trying to avoid that so that you're less likely to form more crystals. And also what we call purine-rich foods. So, and purine-rich foods. And I can tell you that if you watch your diet and you are careful with what you are eating, you can avoid flare-ups, okay? On top of, you know, and the few times I had a friend and he was like, in chiropractic school, he was like, I like my alcohol and I like my shrimp and I like there's a couple other things he liked to do, and he knew he was going to pay for it the next day. And then when he cleaned up his diet when we were getting towards the end of school, he looked a lot better because he felt a lot better and he wasn't limping around and in all that pain. So, so hydration is key. Diet is going to help also. Apparently we're out of time, and so we're going to start chapter 10, muscle tissue, on the next lecture. And I will bring up the clickers for you guys now.